Good afternoon and welcome to the 4 o'clock work session of the Douglas County Commission for Wednesday, February 26th. Today we are hearing from Bert Nash, who's providing a 2024 financial review and previewing their budget challenges for 2025, although we're through 2 months, so we may not be previewing it. We may be experiencing it. As in all work sessions, it is for information purposes only. We do not take any votes at work sessions. We do not take public comment at our work sessions either, but if you'd like to provide public comment on the information shared today, we welcome you to our 5:30 business meeting. And with that, I will turn it over to...
I don't have any opening remarks, so if just Patrick, if you turn it over to Patrick and if you introduce your team.
Thank you.
Thank you, commissioners and county staff. I'm Patrick Schmitz. I'm the president and CEO of the Bert Nash Center. With me tonight up here is Mike Miggs, our senior director of finance and administration, and our clinical director, Dr. Kirsten Watkins, who's going to also serve as the slide driver, I guess, for the evening. I'll just quickly do a quick outline. My intention, I think, is we have 12, 13 slides. My intention is to go through the first 9 slides with you. It is kind of a recap of what we saw in 2024, some of the lessons we're learning, some of the things we're experiencing, give you some time to ask some questions in between that, and then before we move into 2025 challenges and what we're seeing. Is that fair? Okay. I know that we are trying to also keep this to the 1-hour time slot, so I'm going to be very mindful of that. So I'll get started. If you want to put up the first slide, it's just the Bert Nash. There we go. And I'll just give you a quick, just for anyone who's listening who really doesn't know much about Bert Nash and community mental health centers, just a quick brief overview. Bert Nash was established in 1950 in honor of Dr. Bert Nash, who was an educational psychologist at KU and influential in our community as well as across the state. It was set up after his untimely death. And in 1961, the state of Kansas finally established the public mental health care system, saying that counties can either establish a CMHC on their own or set one up as a not-for-profit freestanding entity, which most of them have done, although there are a few that have stood up their own, Johnson County, Sedgwick, and one in the southern part. I always get it wrong because I want to say Cherokee, but I know that's a county in Iowa that I always remember. So one down south. And anyways, and it allowed also for the counties to fund mental health services. And then in 1974, the state of Kansas began funding them. So eventually the Bert Nash Clinic became the Bert Nash Community Mental Health Center, one of 26 currently serving in that role as the public safety net provider. Per Kansas statute, we are, Bert Nash and other CMHCs are required to serve all within our catchment area who have a behavioral health issue and who are uninsured and underinsured. This latter part becomes really salient as we go through the presentation this afternoon. And in 2022, we became a certified community behavioral health clinic, which required us to significantly expand services. It actually dovetailed well with the investments we had been making in our community around crisis services and a number of other things. But it did require us to do more, including expansion of community-based services, substance use disorder, integrated healthcare. In general, it was a very net positive, brought in a significant amount more funding, but did require a lot more work. So our purpose is to review what that has looked like in 2024. So you want to show us the next slide, please? Okay, so you can see since 2018, we have seen a significant increase in expense. Obviously, we've also had a significant increase in revenue. But you can see in 2018, we were roughly a $13 million organization. In 2024, roughly a $41 million organization. And you can see the significant growth once we became a CCBHC. Next slide, please. So service delivery, that first box there under actual year-to-date services provided 162,557. That represents a 2.5 time increase over what we provided in 2020. So we are providing a significant amount more services. As you see, we anticipated 138,000, and we actually provided nearly 24,000 more in 2024 than we anticipated. The next line you see is visits. Visits has to do with the PPS, so the prospective payment system payment model, sorry. That is that first service in a day that triggers the PPS. Now, we only get paid when it is that service is provided to an individual with Medicaid, but we still count everyone who gets a visit, a service as a visit. So we anticipated Medicaid visits in 2024 being 45,000, almost 46,000, and we're short of that. And we'll talk to you a little bit about why that is, or why what we are seeing as a result of that. But you see that variance there in the blue box below, that less amount of PPS visits calculates to about $1.6 million less than anticipated generated from the PPS. So next slide, please. And we can look at the very specific areas that we expenses and revenue. So the bulk of what we provide or what we spend our money on is our staff. 80% is that. So you see that big amount there under salary and benefits, and then everything else from there flows in. And the middle column is what we budgeted. Of course, the first column is actual, and then the variance there for the year. And then down below is revenue. Fee revenue, 24 million. It just was what we had hoped for, 26.7. County came in right about where we thought it would. Grants and contracts was down a bit. Fundraising was up. And so we had a net variance of 1.9 million less than what we budgeted for. The actual was about $500,000 less when you factor out expenses over revenue. So next slide. So this slide and the next this slide and the next two slides show you some information about who we're serving by primary payer source. And what you will see, one, as you look at that trend line, you see we're providing a lot more services. The orange line is Medicaid. The blue line is commercial. So you see we are doing a significant number of more services to those with commercial insurance as well as Medicaid. And that middle line, kind of the teal line, is one that is skyrocketing, and that is those without any insurance. So we are providing more coverage for those with no insurance and those with commercial insurance. And the challenge with the commercial insurance, while we love working with that, is they don't cover our costs. The only entity that covers our cost is the Medicaid PPS rate. Because that is factored, as you recall, if you've listened to many of times where we talked about the cost report, that is what factors in and calculates what it costs us to deliver care. And so the more commercial insurance we provide and the more uninsured we provide, the less we're getting paid. And it's becoming challenging as those numbers have grown. You want to go to the next slide? And here is a slide that shows you a percentage of individuals served by that primary payer. Again, you see that commercial is up there. Medicaid is still strong, but as an overall percentage, it has not kept up. And then, of course, the uninsured has, you see, significantly climbed in the last year and a half. Part of that has to do with in 2023 to 2024, the state of Kansas, as every other state had to do, is unwind Medicaid enrollment. And in the state of Kansas, about 114,000 Kansans lost Medicaid. Roughly 21% of Kansans were disenrolled from Medicaid, and we have seen that impact at the Bert Nash Center. Not the same percentage drop, but ours has been certainly a significant impact on us. I'm going to catch forward on my slides here. Next slide. And then this is back to the visits. The visits for us, again, are the things that trigger that first event of the day for service. Now, somebody who comes in for therapy, they're likely just to get therapy for the day, and that's it. But we do serve a number of people that might come in for therapy and then also see their case manager, or they might see a physician, or a service such as the TRC. They might see that clinician when they get evaluated in the urgent care unit, but then transition back to observation or stabilization, where they will get a tremendous number of services, but it's still the one visit. So there are some services that some places where it is service rich, visit poor. Yes.
So if someone stays at the TRC for more than 24 hours, does that count as a second visit then for that PPS rate, or is it only one?
We can trigger that again the next day. Yep, after that period of time. What's important is you see that is the Medicaid percentage has decreased. And again, in part because of Medicaid unwinding. And this is one that shows for the last year and a half. So it kind of corresponds with the Medicaid unwinding. You see then also the blue line where the uninsured has climbed up for us, whereas the commercial as a percentage has stayed about the same. But we're providing a lot more to the people with commercial insurance, and therefore, in a sense, you're selling more of your toilet paper at a loss, right? For lack of a better thing, you're just selling more of it, losing more each time you deliver that. So let me see where I'm at. One of the other things that we noticed, and Dr. Watkins can certainly address this, is since we have come out of COVID, the number of people coming in for services has increased significantly. And that's not just at Bert Nash. Our colleagues are seeing that across the state of Kansas. Private practitioners are seeing that. The need for mental health services has continued to grow following COVID, which matches the last time we had a significant pandemic. The need for services continued for 5 to 10 years following that pandemic. So cost of care, next one. So here, breaking this down, the cost of care by payer category, you can see there's our total cost of care in 2024 was $42,193,000. When you break down what it costs us to provide that care by provider type, you see there's a significant cost to the uninsured and the commercially insured, as well as Medicare. And our revenue nowhere near matches the offset that it costs us to provide that care. For just the non-Medicaid fee revenue, so Medicare and commercial, we brought in about 3.4 million and 1.4 in Medicare, but the total cost of that care was 9 million. So that was roughly a $5 million difference between what it costs us to provide that care from what we actually received. So does that make sense? Okay. All right. Questions?
So help me understand, if I have commercial insurance and I come into Bert Nash and I receive services, if I go to my doctor or my dentist and I do that, there's a copay related to the
Yes.
cost of care. Is it the same at Bert Nash?
Yeah,
Okay.
well, I shouldn't say it's the same, but yes, there's a copay. It might be different because parity hasn't been fully implemented, which said your cost of care for behavioral health should be the same as it is for your medical, and that unfortunately hasn't happened.
But there is
There
a
is copay.
cost for those who have
Yes.
commercial insurance
Yes,
for them individually.
yes.
Okay.
I'm going to have you reiterate just,
Sure.
so in terms of someone bringing in private insurance, what's the gap between what you're being paid to render those services and what those services are costing?
It can vary widely depending on the insurer, the insurance company. So we have some that pay us fairly well and others who do not pay well at all. That gap can be, again, our PPS rate is, what was that, Mike, 457. I think our best payer probably pays us, commercial payer probably pays us 106, maybe 130 for some, but for an hour of therapy. So you can see, we would normally, if they were Medicaid, we would get 457. A really good commercial is significantly less than that.
And the cost to provide that care, is that the 457 or is it somewhere in between there?
The cost is what the cost report shows us, which is 457 in 2025 moving forward. Yes.
And who are your primary payers for commercial and Medicaid?
So on the Medicaid, we've got the three MCOs, Healthy Blue, United, Optum, and Sunflower, which is, who is it? Centene. So, but their name is Sunflower. On the commercial side, it is Blue Cross Blue Shield, United Commercial, Aetna, and Cigna. Those are the big four, with Blue Cross Blue Shield being the largest one that we have.
So when you visit with your colleagues on the physical health side, are they reporting the same thing, or is this something specific to mental health on the reimbursement rates from private insurance?
I would say that in general, healthcare, and I haven't had conversations with my primary care friends, but what I know is health insurance typically does not cover the cost of care that they have to provide. Our challenge is we are very limited in how many other things we can charge you for. So we can charge you for what we deliver. We don't do a lot of ancillary things around that. So like if I get hospitalized, I get a bed charge and all that, but I'm getting charged for my box of Kleenex, my lip balm, and a lot of other things that help them offset it. And if you've ever looked at your explanation of benefit you get back from your healthcare provider, you see, here's what they charged, here's what was allowed, and here's what they paid, and then maybe what your portion is. So we all have that. I don't know anybody who gets fully that cost of care. Our challenge is we have to provide care to everyone. We're a specialty care. So we provide care to high needs, high acuity individuals, as well as we've been providing a lot of care for individuals who are not as high acuity, and that has created a challenge. And Dr. Watkins can talk a little bit about her experience with that and some of the challenges her team has in trying to get them in for that care. So again, part of our thing is we are a safety net provider. So unlike maybe your typical primary care provider who doesn't have some of the same requirements that we have, that adds to it. We have a lot of requirements to be a CMHC, CCBHC in terms of data collection, reporting, quality standards, documentation. We have a very high administrative cost as a result of BNA, CMHC, CCHC.
And when will you be renegotiating your contracts?
We are in the process of renegotiating our commercial contracts right now, in fact.
With all of them currently?
With those top four, yes.
Okay, all right.
Yes.
And then have you had any conversations with all of them in the meantime in regards to bringing them to the table to have conversations about partnering with them with the population that you both serve?
As you and I talked about yesterday, we have not. And so that is something that we will start talking to them about. Is how could we, while we work on this piece, what other things can we do?
Okay. And do you want to talk just a little bit about that so that anyone who actually listens to this working session might understand what that would look like?
Sure. So one of the unique things about, of course, being who we are in terms of the variety of services is we can offer an entire package of care. So from your entry level care where I'm just kind of struggling, but I need something, but we can take a team and help that individual, right? So we have the therapists, we have the med providers, but if they start to get having more challenges, we have case managers and behavioral health specialists. We have crisis workers that we can provide. So we can wrap around some services for that group of individuals at a rate that would save the health insurance company money in the long run if they don't allow us to provide that level of care to the individual. And then they end up in a much higher level of care. They end up in the ED, they end up in an acute care facility, or their health deteriorates, and then you've got a lot of other expenses related to that. So by offering them a variety of things that we can better take care of their members in a more proactive manner, we can help them have an impact on healthcare costs in other parts of their system. So. Thank you for the question. Other questions? I'm sure I'm mindful of our time. Okay, we'll move on then to what we're seeing moving forward, the 2025 budget. So as I said, our challenges as we've moved into 2025 is how do we match up what we have been delivering versus what we get paid, some of our aspirations here in this community and how we do things. Are they realistic to keep doing at the level that we've been doing moving forward? This budget would say, no, not without some changes, some things that we need to do to really look at this differently and address it differently. So here's where the budget, and we haven't finalized our budget yet this year. We've been working through this actually for quite some time. A significant amount of effort has been put into getting to where we're at today, and we have some more work to do. But right now, total budgeted expenses is approximately 4.3 or 43.7 million. Again, that number will fluctuate. It's approximately 1.7 up from 2024. So we do not plan on significant growth. And you see the vast majority of where we spend our revenue is on salary and benefits. Ours is a very human delivered service, and it takes humans to do that, obviously. And so that is the bulk of what we use our resources on. Rent, utilities, building maintenance, and you can read from that, but you can just see the vast majority is on our people. Moving on to revenue. Here's where you see approximately a $1.5 million $1.5 million difference. It is up a bit, but it is not obviously where we need it to be. So fee revenue would account for approximately 59%. County funding, approximately 17%, state funding, 13%. For some perspective, the county at one time was about 25% of our budget back in 2018. Wildly different budget, but just so you have a sense of that, I'm not saying it has to be at that level. I'm just giving you some context. We've done a lot to try to drive that down. Another point was about in 2018, Medicaid revenue was approximately 5 million. Today it's about 22 million. So we're bringing in a significant amount more Medicaid revenue into our community that helps pay for people delivering care. So,
Patrick,
yes.
excuse me, I have a question. Since you mentioned the difference, just for some perspective about the county funding over time, how's that state funding slice of the pie changed? Has it fluctuate significantly over time? Has it been a meaningful impact one way or the other?
Yeah, the state funds have increased over time as well. Probably I guess I haven't calculated the percentage pace like we had here, those, this year, I should have brought that contract. I think we get how much from the state approximately, is it just over on the mental health center side, not the TRC. So the TRC, they provide 3.1 million. I think on the mental health center side, it's roughly 2.3 million. Don't quote me exactly on that. I was just looking at the contract the other day, not for the numbers, but we're in the midst of contract renegotiations right now. And there's 3 buckets that we get money. One of them is about 1.8 and the other 2 are like 150 and what's that?
Broken out.
Make sure you use your
Yeah,
microphone if you, that's all right.
The mental health block grant is kind of a separate piece of that, but it's roughly in total 2.2, 2.3.
Yeah, I guess, yeah, and thanks for flagging that the
mhm.
TRC, is
Right.
a sort of distinct addition that has come on,
Yeah.
besides what historically has happened over time. I think, I'm just interested to know, I mean, it sounds like it's increased, certainly in dollar amount, but I would be curious just to
Yeah.
have some understanding of relative, percentage and
Percentage,
share of it and whether or not, there's opportunity.
Yeah.
There.
Yeah, the state provides approximately, if I remember right, approximately $56 million for the mental health reform grant dollars that they provided us. Then that is divided out amongst the 26 CMHCs on a couple of different ways. One is based on your population, and then there's a straight amount that all of us get, like a base amount, if I'm not mistaken. So our amount this last year, this current year, we're in state fiscal year, it's roughly 1.8. We do have a request for an additional 6 million to be added to that 56. So if that makes it through, which so far, knock on wood, it is moving forward, we will see some additional revenue. The other bucket of money that Kansas gave us this last year was $1 million towards the development of the Youth Recovery Center. So some of that has been for capital and some of that has been for programming, so staff to develop things. So the state has been very generous to Douglas County, I would say almost disproportionately so than the rest of the state, or at least some of my colleagues would say so, because of how much we've gotten from them. So.
Patrick, I know you have a lot of capital projects kind of in the works. How are those reflected in the 2025 budget?
So they really are not, other than we do have a few funds in the fundraising for expenses we expect to spend on, say, the Youth Recovery Campus. But beyond that, there isn't anything in the budget itself for capital, because we're not planning to do any kind of building or refurbishment until by 2026 at the earliest.
Right.
And that includes the facility that you were constructing just north of 6th Street, west of Iowa.
Yeah, the Rockledge project, yes.
So that's a 2026.
We're hopeful, but we'll see where funding goes on that, because there's been some, some slowing down of state and federal support for unhoused. So we've got some commitments. We need more. So,
And so all those, all that fundraising effort is separate from your operating budget that we're looking at here.
yes.
Patrick,
Yes.
you mentioned the number of services has increased.
Yes.
Correct? Okay. Do you have a breakdown of the services by use? Just curious, like what that looks like by service. And then are you forecasting for the future what that looks like so that like trends, right? Are certain services trending higher? Because you mentioned like due to COVID, right? The pandemic,
Right.
you are expecting that potentially maybe to increase? So are you seeing certain services by type? Are those ones trending higher? And maybe some of your other services maybe are not trending as high?
Therapy is definitely trending higher, and Dr. Watkins can talk to that. While she does that, I'll look to see if I have a breakdown on some of the others.
Yes, I would say that the two most requested services are adult individual therapy and medication services. So those are the ones that are far and away requested over our other services.
Part of that is, quite frankly, there's a limited number of psychiatrists in our community who are providing care. And the other part, the other reality is, while we have a fairly robust private practice workforce, many of them will not take insurance, or they will only take the very best paying one, which is the Blue Cross Blue Shield. So if you have United, Aetna, Cigna, they are saying, no, if you want my services, it'll be a full fee, and that full fee can be somewhere between $150, $200 or greater. And so what we're seeing is more of those individuals are also coming to Bert Nash because we are accepting their insurance.
So then some of your services also have a tendency to trend lower simply because they're not covered?
Some of our services are certainly for special populations or
Mhm.
people in high acuity needs. So you've got like the assertive community treatment team, right? It's a smaller team, but serving very high needs individuals. So I think the caseload right now on ACT is about 40 to 45 people for the size team that we have. Whereas, again, you've got an outpatient therapist who might have 40 to 50 people on their caseload seeing, or higher, seeing, 20, 25 people a week. And so it really can depend on that. Yeah, I hope that answers your question.
Yeah, okay.
I do have a breakdown by the service, but it's not a trend. So I'm not sure that that's necessarily, and it's not by percentage. So, but
Okay.
we can work on that.
Okay, thank you.
Yes.
So Patrick, I just want to make sure I understand. So if I have private insurance and I go to a private provider
Mhm.
and they say, no, we don't cover your insurance, and then they come to Bert Nash, we provide that service and we expect the county, Bert Nash, other people to provide the difference in that the private practice would not provide.
That's
that it?
fundamentally part of why we're here to talk about that. That has kind of been our philosophy, providing care to everyone. Can we continue to do that? And how do we do that in the midst of an expectation we provide care to everyone? It's a conundrum, right? And how do we navigate through that? It's something we've been talking about. And that's why we said we need to elevate this conversation here so that our community can understand, here's the challenge we're at. We've done a tremendous amount of work. I don't think we've said no to almost anything. But this is where that puts us. And so what do we need to do collaboratively to address this differently moving forward so that we can continue to take care of our community to the best of our ability?
Have we included any of the private practice groups in the conversation at all?
Not yet.
Okay.
And to your point, Commissioner, this is one of the reasons why I mentioned that I think it's also important to bring our payers to the table because the population that they serve, that Bert Nash serves, is also the population that our payers serve. And so it is of equal value to all parties to ensure that the population is being served, the whole person is being served, and that all parties are equally valuing the taxpayer, but also valuing the individual and coming collaboratively to the table to ensure that the intervention that's actually being developed is being developed for the individual and is being developed for the community so that we don't have just one entity with the county paying for the services when we know that the payer should also be at the table as a stakeholder in the conversation.
Yep. And we're having maybe not similar conversations with the state, but I mean, in this kind of setting, but yes, we're having those conversations with the state as well. It's why I've been. While Stephen's on his way up. So I've been to the State House many times, more times than I had been previously, provided multiple testimonies, multiple times meeting with legislators and in conversations directly with KDADS, who is a significant supporter of ours, and how do we bring them more and helping them understand. Spent 2 hours yesterday in contract negotiations with them, helping them understand what's going on and what their role in this can be. Stephen?
Yeah, Stephen O'Neill, Chief Operations and Strategy Officer. Commissioner, what you said about bringing the payers to the table, I've spent the last 7 years engaging these folks, and it is literally like throwing yourself into an abyss. They fundamentally care about generating a profit. So when you ask them if they will increase your rates, what they will start with is, this is our market rate for the state of Kansas, and we don't have any flexibility. That's what it feels like when, and they'll say they want to come to the table. They'll use words like value-based care. They'll use words like win-win. That's not what is happening. Their job is to return a profit to their shareholder, period. And that is clear in the negotiations. We actually, even to get them to listen to us, hire a professional insurance negotiator. And it is still nearly impossible to get anywhere with them.
And I think one thing that, and Stephen's right in that part of it, but as Commissioner Anderson and I were talking yesterday, we might also want a different approach and it requires something different from us in terms of collaboration and showing that with the full package of services, we might be able to really save them money, which then allows them to return more to their investors. This will not be a solution for next week. It will not happen next week.
Our services are actually really expensive, so it doesn't save them money. What we've built makes people better and it keeps them safe, but it doesn't save money. The TRC is expensive. The mobile team is expensive. It's more expensive to go to the TRC than it is to go to the hospital or jail or almost anywhere else. So the value economically is not there, and where the economic value isn't where the expense is. So other people are benefiting from the TRC because they're not serving those patients. But the notion that an insurance company is going to negotiate an agreement with the Bert Nash Center that is going to save everyone money, I think is false. And I'm leaving in a couple weeks, but I've spent 7 years on the front lines with these insurance companies, and we got stuff done with them that people said we couldn't do. We got the TRC paneled, but it's hard, and it can feel futile and spirit breaking. And at the end of that is a human being in front of our staff trying to get service, and employers aren't covering the cost of care. So sorry, I just had to say that because Bert Nash has done all of those things. We have begged, we have hired experts, consulting to negotiate, and we may have to walk away from some of these agreements.
I hear you, and I appreciate your time and your diligence in having those conversations, because I know that it can be very difficult. And even as you're having those conversations, many payers are engaged in mobile integrated health and community health workers and hiring those individuals. So knowing that Douglas County has invested in those programs, I think is also a fantastic opportunity for collaboration, because you can leverage those programs that already exist within Douglas County, which is also a cost-saving advantage for payers if you can message and bring that into your strategy.
That fits with some of the work that we're on at one point around behavioral health leadership group, and how do we better coordinate care, and how do we strategically align ourselves so that we are in a better position to the external market, and help keep that. So yeah, I think that all fits in that. It will take some time, but nothing good comes without that time. I mean, we learned that during TRC. Took some time, but a lot of lives are being saved as a result of that effort that we went through. So moving into a couple other slides, and then we can, again, I'm being very mindful of your time. The 2025 budget proposal assumes a few things. Cutting new positions by 90%. So we had hoped to create some new positions, do some new things, and we have said no. So this budget was even bigger difference before, and we said no new things except for very limited. Our partnership with the health department, the integrated care that we're doing, that we said yes, that one we must do. We need to move it forward, in part because individuals who are served there can get served at a lower level. And more efficiently, primarily around medications. So maybe Dr. Dodson's team stabilizes somebody really well on medications. Maybe we can't get them back to their primary care doctor, but the partnership with the health department would allow us for them to continue med management through that provider at a lower cost, and keep it moving forward. So those things. Open positions, we cut 65%. So those are people that had left. They were open positions. We just said, oh, we're pausing on those. We're reducing our fund for training for our team, and delaying investments in workforce. So when do we give raises? Those are delayed, way out. And if we'll see. And then selling the Bridges house. If you recall, Bridges is a transitional housing project. It's been very minimally used over the last period of time. So this assumes that. Does that mean that's what we're going to do? Not necessarily, but that assumes us saying, okay, we need to move away from that building and cut the expenses of operating that. But we'll see. Again, these are just some of the things we're looking at. In some of the particular services, you can see where there are some pretty significant gaps. The mobile response team, obviously that is a very expensive thing to do. And we need to look at that. Treatment and Recovery Center. You know, we had hoped that we would be able to limit our county request to the 1.6. And we probably need to reconsider that and look at that differently, given the variation in what we saw in terms of people who are coming in. It does not have a high Medicaid penetration rate. A lot of people that come in are uninsured. And so the cost of care there is a lot. The transitional housing project transitions, there's a gap there. As Dr. Watkins has said, one of the big ones is the outpatient services for the uninsured and underinsured. And then, of course, assertive community treatment, which we've talked about. It's a very expensive one, very high needs one. And so we have to, think about those things. Next slide, please. So some of the things we're looking at for the path forward, again, as I've mentioned, legislative requests for our mental health grant and the CIC funding, the lottery vending machine funding, been to the state to advocate for 12, it's currently at 9 million. There was two different versions. One was a $12 million request. The other was a 16. I'm not sure where they landed. It is moving forward, but of course the budget isn't done, but we will continue to push for that. Look at raising our prices, making sure that we are charging what we can for at the maximum, so the insurance is paying the maximum they will. That could have an impact, though, of course, on clients. Adjust our sliding fee scale up. We're in the process of negotiating the commercial contracts. We county support, fundraising, and then, of course, continue to seek capital grants for projects that we are working on. Expenses, portion care. How do we deliver care? Is it unlimited, or do you get 4 episodes of this and 2 episodes of that? Many places, that's how they do that. Focus services on our priority populations and crisis services, that high needs, is that where we really need to be focusing? And again, this is part of the elevation of the conversation for us to really decide what do we want to be and moving forward. Reduce rented space and costs. I know we've had some conversations around rent and a building that we recently purchased at 3510. Why would you buy a building? Because it will allow us to get out of a significant rented space that we have currently. It's not going to be an immediate answer, but that's one thing that will get us in the right direction. Increasing our partnerships for services, and how do we do it differently, and be able to get different types of referrals and things. And then again, I said, as I mentioned earlier, selling bridges. So I think, in summary, we have been meeting with county staff over the last couple of months. We meet with you as a quarterly to do a financial review. Obviously, I meet with Sarah more often. Bob meets with a number of my staff for different things. And so, and of course, we meet with Jill as well. So we've been talking about these things for some time and being well aware and needing to come together. And because we are your community mental health center, and you are our most significant partner without question. We exist because of you. And so any solutions require us to be together and collaborate and moving forward. We would rather have this conversation, as uncomfortable as it is, versus putting our head in the sand and not having it and see what happens and just take a guess. No, we don't want to do that. We want to be a part of that and bring that out here. So we're committed to continuing this work, continuing in our partnership with you, with the community, with the state, towards continuing serving our community. We're coming up on our 75th anniversary. Now I won't be around for the 150th, conceivably, unless medical advances change. But I would love to be able to say someday in the future, somebody says 150 years, hopefully 100, or at least 100, but 150 would be amazing. So questions?
Yeah, Patrick,
Yes.
Being a CCBHC, can you really ration care out?
Dr. Watkins, did you hear the question?
Will you repeat it again, please?
Can you really ration care out under CCBHC guidelines?
I think my answer to that would be that we always are thoughtfully making decisions about care and trying to match people with the services that they need. Those are always clinical decisions that we make with thought and care and are very considerate of what services are available and what we can offer folks.
I have a question. So Patrick, when you and I had met earlier a couple weeks ago, we talked about, so since 2020, there's been a 250% increase.
2.5. Yeah. Two.
Yeah,
You're right.
so
Yep, same.
2.5 times
Yep.
increase in the number of clients or the number of services being provided. But also over that same time period, the amount of staff has increased greater than that. Are there areas of efficiency that could be pursued when you're looking at matching your revenue and expense?
Part of the challenge is some of the push that we've done has been in high level care. So the TRC being one, right? The TRC team is approximately 100, a little over 100 team members. It's a 24/7 operation, requires a high level number of staff and highly qualified staff to be there at any given time. So you can't really reduce the number of people there without reducing the capacity of it. And and we're not staffed at a 32 individual capacity. We haven't reached that level, and where I think we're at 24 right now at max, which we don't get there very often, but you have to staff for that. So that's part of that. How do you do that without cutting what you're trying to offer?
Can you also look at, so the Douglas County funding portion, I know we fund some specific programs, and is the rest of that then to uninsured and underinsured care? Can you just talk about the breakdown of where that funding goes?
I'd say Sarah might be better. Or Bob, yeah.
Bob can correct me. I think everything's allocated to particular programs.
Yeah. Everything is allocated to particular programs.
Excellent. Thank you.
But I think one thing that's important to keep in mind is as Bert Nash has changed, has moved into the CCBHC realm, there are things that are required by the federal government, by the state, that you must offer through CCBHC. Assertive community treatment is one, 24/7 crisis services is another, mobile response is another. So another part of the conversation, I think, is how much of that required mandate for what a CCBHC does should be carried with local dollar costs.
That was where I was going next. so thank
And
you.
what's realistic in terms of what they aspire for us to do versus what is reality. And this conversation that we're having, my colleagues are having elsewhere, like, hey, we know you're asking for us to do this. Here's what's realistic. This is what we can drive. We would love to do what you want us to do, but here's what we have the funding to do. And you're going to have to live with that.
Well, and specifically the funding from the entities that are requiring that you provide those
Precisely.
services.
Precisely.
Particularly in a state that does not have Medicaid expansion, because, I think that was information, Patrick, that you shared with us, that Kansas is the only state that has done CCBHC expansion that has also not expanded Medicaid.
Right. And so therefore you miss capturing some of that additional support.
Patrick, on the TRC, isn't of the 900 and some odd $1,000 loss, isn't over 800,000 expense in rent that we pay the county?
Our rent to the counties are roughly, it's over 800,000. It's roughly 73,000 a month, I believe. So it roughly comes out to about 840-ish.
And we structured that because initially it helped. Our
This was
understanding
not
is
done.
that
yes.
rent was used to help us draw down more federal dollars through the CCBHC.
When we did it, there's no clawback now, though, by the state.
Right, yeah.
So that might be an opportunity to provide some relief.
Correct.
So one of my questions is very technical, and it's just about your fund balance as an organization. I went back through our some of our, is it still around that $3 to $4 million range on fund balance? Is that right? That's what it's been in our budget
I
packets.
believe, Mike.
Yes, the 3 to 4 million would be correct. Most of that is in our endowment. Obviously, our cash position is pretty minimal. We ended up here in 2024 with about 200,000 to 300,000 in cash. So most of our reserves is our endowment.
Okay.
Yeah. And it's a true endowment where it provides some support, 5% of its 3-year rolling average every year. We did take a 1.5 million withdrawal from it to implement the CCBHC, but it is not something we can just easily pull to fill a gap.
And then my next question is maybe a little broader. I was looking down the key program gaps, and in the time that I've been here, most of these are things that we have done while I've been here. And each time we've had Bert Nash come and we talk about it, we felt like it was something that we could accomplish within our budget parameters. And here we are, and I'm looking at 5 programs. I'm also thinking a little bit about RAP and those things. Like each time we've said we're able to do it, we're able to do it. What are we learning along the way so that the next program that comes up, we're asking questions so we're not in this spot with the next program and the next program? Is there something to learn there?
I would say that part of it's a shell game in the sense that we used to have funds that the county gave us for our health insurance, and that has been reallocated. And we've always had gaps in programs, but we were able to cover those gaps in other areas of our center because we had the support of the health insurance. So when we talked about moving away from the county's health insurance and those funds being reallocated to programs, those did help to close gaps on certain programs. Didn't necessarily close all the gaps, but it did help with the gaps that we had in those programs at the time.
Say that the other part is the change in the client mix, the payer mix, has been a significant driver. So every percentage less that we are doing in the Medicaid PPS is roughly $225,000. So we see that drop. That's a drop, and we've seen that as in part because of the unwinding. Obviously, the other thing is the reality that things cost more. Since the pandemic, our cost of care has grown significantly because our cost to employ people has gone up significantly. We did a market study a year and a half ago, implemented significant raises, and it just as quickly our competitors raised theirs up and above that. And so we continue to fight for a market share in the sense of the talent pool. And so that is another part of it, is the reality of what it costs us to employ people is going up. Sarah, did you have?
Well, I was just going to say, Patrick, how many community mental health centers in Kansas take private insurance? Do you know?
The vast majority do not take it at the level that we do. I think we're at roughly 30%. I'll give you an example. Wyandotte is at 4%. Johnson County. Stephen, do you remember Johnson? There's under 10. Sedgwick, very limited. So we serve a much higher commercial panel than the vast majority of CMHCs. They, for the most part, stay very focused on what we call the priority populations. Adults with severe and persistent mental illness, children with severe and emotional disturbance, the Medicaid folks. Whereas we have aspired to take care of our community holistically.
Patrick, I have a question to piggyback off that, and it might be jumping far down a rabbit hole, as my tendency is. Do you have any information, maybe from your colleagues, about what the ecosystem in terms of the private providers looks like? Are they facing a similar situation, both in terms of maybe a lack of, a severe lack of private providers and therefore alternative options to the community mental health center, as well as that what sounds like a growing universal truth of private providers not taking private insurance? Are they facing the same challenges, and therefore we sort of have this different, maybe less acute need group of people in those communities who are not receiving any care anywhere.
I am hearing that, Dr. Watkins. You meet with the other clinical directors.
Yeah, my perception is that this is a challenge for many different places, but some of those agencies that you mentioned have more robust options for outpatient services in those communities. So they have other agencies or other clinics that are able to also provide an option for people with private insurance.
And when you say that, I'm sorry to interrupt, I just want to clarify, like other nonprofit service providers that just don't have the CMHC or CCBHC, or you're talking about like private providers in a practice?
Could be all of the above.
Okay.
So
Thank you.
large private practices that can take many people, hospital systems like KU Med or other places that offer options for people with insurance to receive services. There are less of those in this community. And the trend we've referenced about private practice providers taking less private insurance, that's a national trend that we're seeing. So it's not unique
That's
to
not
our
unique.
community, but clearly creates some challenges.
I have another question about, well, how do I want to frame this up? You know, when thinking about the different ways in which to approach private insurance providers differently. Is there a different strategy? Is there another perspective? Is there some hook? You know, as we were sort of exploring that conversation earlier in this work session. I'm just also thinking about what other levers there are to pull that maybe are not naturally thought of as advocacy partners in this work, but I'm thinking about large employers and what sort of weight and pressure they have to apply to their insurance carriers. And so, and you know, the large organizations and businesses in our community who are have significant numbers of people who may be seeking your services that are struggling with the reality of their private insurance across the spectrum, not just with respect to behavioral health. So I'm just curious, maybe those conversations have been happening, but thinking about how businesses and other large organizations can help or play a role.
Yeah, they need to be a part of that. And whether it's part of the broader conversation Commissioner Anderson was suggesting, or we just need to start having it. But yes, entities that buy health insurance can help influence what they're purchasing and what they're being offered, especially if you are self-insured. You can really drive where you want to spend your dollars, and spending your dollars in lower cost care services such as therapy, psychiatry, that intervenes early on and at a more effective level is certainly less costly than ended up in the ED or an acute care facility or the like. And so, and it helps people become more productive and back to work sooner if maybe they were off of work or maybe they just weren't as productive. If they're getting that care, they can focus and do. So yes, the investment of employers and purchases of those plans can help influence it.
Yeah, thanks for that. I think I'm interested to understand and maybe explore that more as a strategy, just in part to really recognize and hold space for the fact that naturally, given the reality of the totality of circumstances, you all in the negotiating room with them is a very particular dynamic and power imbalance that is, you know, by some people's measure, impossible to overcome. And that's valid, I think. And so I just am really curious where else it is that your entity, that you know, us as local governments too, can help ask for the additional supports and the additional applied pressure from people that are standing in different positions to those entities and that can pull different levers with them.
I appreciate that. Yes. The questions.
In terms of clients served, Do most of your clients come from Douglas County? Is there a requirement that they have a Douglas County connection? What's the breakdown there?
As a CMHC and CCBHC, we cannot say because of where you reside, we won't provide you care. However, the vast majority of the people that we provide care for are Douglas County residents. The small number that we may provide care for likely are people who work here. So it's easier in the middle of your day to run and get your hour of therapy, see your doctor, versus driving all the way back to Johnson County or one of the other surroundings. So, but that is a very small percentage of the individuals we serve. We sometimes spent a lot of time talking about it, and then we'll get, wait, what's the data show us? Why are we spending so much time talking about this? It's just a small number. So your investment is significantly, I would almost say 100% going for your citizens who are paying for it. The state's funding helps really support everyone else because they expect us to do that.
Yeah, I appreciate that.
Yep.
Commissioner Kelly had kind of brought up the low fund balance to kind of cover things like this. But for 2024, you had $1.9 million deficit. How did you cover that? I'm not sure you had that in your fund
So
balance.
again, that deficit was the difference between what we budgeted for versus what was actual. The actual deficit was about 500,000. That's just not in our checkbook right now. And that's where the months or days on hand of cash is significantly strained at the moment.
I'll just add to that. I was comparing on the graph page that had the expenses, and I did a quick what's revenue and expenses and where we ended up. If you were to look at our financials last year, we had like a $7 million surplus. But of that $7 million, maybe $1 to $2 million was from operations. The rest of that was from things like our unrealized gain on our endowment. There's about $3 to $4 million in just capital purchases, sales, things like that. So things I don't consider from operations.
Right.
And the year before we had a $2.5 million loss. So it's like we'll swing from one year to year, maybe a plus million, minus $1 million. But over the last 3 to 4 years, we pretty much netted a break even over those years.
Okay, I appreciate having that context. When it comes to budget time and we get the financials for the last several years in our budget packet, will that be really well delineated between, what is endowment, what is a operational fund balance, what are capital projects?
We can do that. Yep.
Make sure that. Yep.
Appreciate it.
I've got one more question. I know we're a little past the hour mark, but I just, was scrolling back up to the proposed changes and the sort of budget assumptions. And I just wanted to circle back to the cutting of positions and ask for you to, I think I heard you correctly, but I just want to give another opportunity, especially for anybody else listening, or for, the record. The difference in the numbers you put here. So I'm just reading verbatim off the slide, the cutting new positions by 90% and then open positions by 65%. Can you just sort of expand on that a little bit more? And specifically the open positions, I'm interested in understanding because that's significant number to me. I just want to understand where you're thinking about that holistically.
Right. Okay. So again, the new positions were hoped for things. Hey, we'd really like to add a team that could really focus over here. And we've said we just can't do that at this point. Would love to, but here's the reality. The open positions were, let's say, a therapist who'd left. And instead of immediately filling that, we've said, who can these individuals go to instead of filling that position? And I don't have that full list. The majority were new positions, not existing open positions. But there was still a fair number. So it's that kind of thing where we've said, yeah, we'd love to be able to replace that person, but we're going to wait and see if the rest of the team can absorb that work. Mike, do you have some additional, because you looked at that list a lot more than me.
Yeah, I would say that it's a splattering between the clinical providers as well as, say, back office administrative. It was a combination of the two.
Yeah, there, I
Yeah,
mean, there
thanks.
is.
That's
I
what
mean,
kind of what I wanted to ask is if
Yeah.
there was a spread or if it was really focused on one or two departments or types of providers and that those open positions that have just been vacant and you haven't filled, is it going to hit any part of the organization hardest? I didn't
Spread,
articulate
yeah,
that
yeah,
well
no,
before,
no,
but.
that's great. And I'm glad, Mike. Yes, it was throughout. So yes, from direct service providers to back office to executive leadership.
And we have your, the revenue gaps, the program revenue gaps that you'd identified. That's within the 2025 budget that is still being crafted or recrafted. Is that correct?
Those are what we would project, yes. And so, yeah, we're still working through all of those.
Okay,
Yeah.
so presumably you'll, when you finalize that 2025 budget, it will be closer to a revenue neutral. I mean,
It's going to have to be.
Yeah.
Yeah. If I had a $10 million actual reserve account, we could probably go into a deficit budget. What we're going to have to come up with is a budget that is neutral or not, maybe neutral. It's never perfectly neutral, but it can't be a gap budget.
Any more questions, commissioners?
Just one comment. We're not taking into consideration currently in your budget potential cuts to Medicaid and also the fact that you now have a union could complicate your salary line a little bit.
Thank you for that, both of those. You're right. It does not account for any potential federal changes to Medicaid. We just don't know where those are. As we know, one day or 1 minute of a day, we think it's this way. The next 10 minutes or 10 minutes later, it could be different. So we're doing the best what we can, what we know right now. With respect to the unionization, you're absolutely right. We don't know where that's going to go yet. We're not sure what impact that will have on all of this, and therefore that's what makes us doing an absolute budget, not just the union, but anything. The way things change around us, an absolute perfect budget every year, nearly impossible. We do our best guess. We go forward and we adjust throughout the year depending on what's coming at us. The federal thing could be a big impact for a lot of providers nationwide.
Make sure we end with saying like how valuable it is, the services that you provide, that Bert Nash provides to our community, how proud we are as a community of many of these pieces that have been put together. And the funding piece is just really difficult. We'll be many ongoing conversations, I'm sure, but I appreciate you bringing it to us and kind of keeping us, apprised of it before budget time. And just, I mean, the more time we can get a chance to ask questions, in our public setting, the better before we get to that point. But really value the work that's done, Bert Nash.
Thank you, and I appreciate you highlighting that. We have 420 team members who every day are saving and changing lives of our community members, and they're having a significant impact. We are just trying to provide a level of care and a type of care in a fundamentally broken healthcare financing system. And we are doing our best. And I will say, as a community, we are doing far better than most in the variety of things that we're offering in our ways of addressing it. It just presents as a significant challenge doing that. But it's worth it. It's worth it to do this hard work because I can walk through the hallways knowing that I see somebody who likely would not be here today if it wasn't for what this team is doing every day. So thank you.
Anything else, Commissioners? Sarah, it looks like you're going to jump in. All right. Well, thank you very much for the presentation, and we will surely continue discussions. We are adjourned until 5:30 for our regular business meeting.